So welcome everybody to today's webinar. I'm going to introduce Dr. Paul Kleberg. Dr. Kleberg is a meaningful use expert. He's the Chief Medical Information Officer for Stratus Health and the Clinical Director for the KHA REACH and the Regional Extension Center for Minnesota and North Dakota. He has led the ONC Resource Center Meaningful Use Community of Practice, which provides support to other extension centers. Dr. Kleberg is the board chair for HIMSS, is an ex officio member of the Minnesota HIMSS Board, serves on the Minnesota Academy of Family Physicians Foundations Board, and has been a family physician and IT professional for more than 20 years. Welcome, Dr. Kleberg.
Thank you. Thank you, Candy, and good day, everyone. I guess it's good afternoon for everyone on the call. The purpose for today's call is to actually give you a background on the two proposed rules that came out, one of which is the change for meaningful use 1 and 2, and the other one is actually the new rules that they're going to have for stage 3. And I think it's good to look at them both together, and then it makes more sense later as we talk about 3, and then beyond that when we talk about 1 and 2, because the stage 3 came out first, and then a couple of weeks later the changes to stage 1 and 2 came out. So again, the goal today is to look at them basically all together so we have a good overview, and we'll go into greater depth on later talk. So, one of the things, as I mentioned, we're just giving an overview. The second goal here is to give you a framework where you can provide feedback on these proposed rules, because as you recall from previous years, CMS is interested in our feedback to understand how we think these will impact us. And there are actually, if you read through the rules, and we'll go through some of them on the next couple of calls, there are questions too about how they think that how they should actually implement some of the things, because they themselves are not sure. So this is basically, again, to give you the opportunity to know how to provide feedback. So a little background on us. We are the Lake Superior Quality Innovation Network. We are 3 organizations that are involved in that. MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin. And again, we're all collaborating together to improve healthcare for Medicare consumers, to share best practices, and also to help maximize our efficiencies in using health information technology and in improving quality. So just as a reminder, you know, and I think we're all very familiar with the HITECH Act that subsidized and pushed forward the use of health information technology in providers' offices and in hospitals. And there are really basically 3 requirements to the HITECH Act. Providers had to use certified EHR technology in a meaningful way. It also required for the exchange of health information. And finally, we had to have submission of a clinical quality data that demonstrated that we're actually showing some improvement in our information. I should also mention, as an aside right now, if you have questions during this presentation, please enter any of your questions during the chat box. I will either try and answer them as we go along, or else wait to the very end to answer some of them at the end. But do use the chat box to ask any questions that come to mind during this presentation. So you're probably familiar with this slide. The stage 1 meaningful use is basically just get doctors to put their hands on the computers and to begin to enter data. And the second stage, stage 2, was supposed to look at some advanced clinical processes. And the third stage, stage 3, was now, here's where we're expecting to have improved outcomes from the use of health information technology. So this is the arc that we're seeing. There are, as I mentioned, these 2 proposed rules. This slide deck is going out to them, correct? So they'll be able to use these links?
Yeah, that's correct. The slide deck will be distributed to participants after today's webinar.
Okay. Because that first URL is kind of a challenge to get to, but The first URL under is Meaning for Use Stage 3. It was released on March 30th, and that actually brings you to an HTML version of the rule. I like the HTML version of the rule because you can actually get links to specific areas within the document. So if you can search the document using your web browser, or if you find a paragraph and you hover over the paragraph, you'll see a little flag on the right that appears, and you can use that flag to copy that exact location in the rule. So you can use that when you need to refer to something or want to answer somebody else's question. So for the Stage 3 comments, those are due on May 29th, just in about a week and a half. And that link actually brings you to a page that you could submit it electronically, but there are also other ways within the rules. You can either mail it in, or there are other ways that you can submit that. The changes to Stage 1 and 2 came out on April 15th, just over 2 weeks after the Meaning for Use Stage 3 rules came out. Again, you got the link to the HTML version of that document, and you've also got a link to where you would submit your comments on that, and those comments are due on June 15th. So this is actually the calendar that was in the proposed rule for Stage 3. And I think you may be somewhat familiar with this because we've seen these calendars in previous years. We see that there's Stage 1 through 2011, 2012, and 2013. Stage 2 has been delayed. We also see on 2014 the asterisk after the 2 because they're saying, okay, it was 90 days for anyone in 2014. They could also do Stage 1. And I'm sorry, I said 90 days. They could also do Stage 1. And then we see 2015 and 16. What we see now, which is somewhat new, is that Stage 3 is now slated to start in 2017. And in 2017, according to this rule, you have the option to do either Stage 2 or Stage 3. And then in 2018, everyone has to do Stage 3. Now, there are a couple of other interesting nuances here under the proposed rule for Stage 3. Everyone in 2017, we'll talk about this later, everyone in 2017 needs to do it for a full year. In 2018, even if it's your first year of doing meaningful use, you need to do it for a full year. The only exception to that on both 2017 and 2018 are those folks who are doing Medicaid only. Medicaid only, if it's your first time, you can do 90 days. But even if you're a provider and you also have some Medicare patients, you would be penalized if you don't do that full year. So, this is what it shows in the Stage 3 NPRM calendar. You see, everyone's going to have to start doing Stage 3 in 2018, regardless of whether they've done meaningful use before or not. And it shows in 2017, you could be doing Stage 1, 2, or 3, depending upon where you are. Well, in reality, and you'll see on the next slide, it's actually contradicted in the changes to meaningful use Stage 1 and Stage 2. What you'll see here in red are a couple of things that are changed on the calendar. Number 1, there will be 90-day reporting in 2015 for all those folks reporting in 2015 regardless of stage. That's new. That's not approved yet, so don't bank on it. But that's new. Again, these are proposed. You don't assume that this is what's going to happen. Providers scheduled to do meaningful use Stage 1 in 2015, they will actually do meaningful use Stage 2 with additional exemptions. And what basically that means, and we'll talk about that later, they won't be asked to do anything new with their Stage 1 meaningful use than they would have had to do if they were at Stage 1. So they actually get an exemption from some of the things that appear in Stage 2. But in 2016 and 2017, everyone is going to do Stage 2 regardless, without any exceptions. So if you look at the grid below, you can see in 2016 I crossed out the stage 1 for those who are starting in 2015 and 2016 and put them down at stage 2 because that's the way it will be. And in 2017, people will be doing either stage 2 or stage 3. So there's actually that contradiction between the proposed rules for 3 and the proposed rules for 1 and 2. I would assume that this one is the one that's true. So that's just a little warning here. For those folks who are planning to do meaningful use for the first time in 2015, yes, you can do stage 1, but then for 90 days, but then starting in January 1 of 2016, you'll need to do a full year of stage 2. So you'll need to start planning right away and start naming your sites right away to be able to do what is required for stage 2. So again, that third bullet, starting in 2017, Medicare first-timers must do a full year. Medicaid only may do any 90 days. So that's, let's say, an oncology hospital or a provider that only sees Medicaid patients. But again, if they have any Medicare, they will be penalized if they don't do a full year. Okay. Again, if there are confusions or questions, do enter them into the chat here as we're going along. Another thing that's changing is in the proposed rules for stage 1 and 2, but you also hear about it in the proposed rules for stage 3, that hospitals are going to be moving to a calendar year. And if we actually look at the proposed changes for stage 1, it actually starts this year in 2015. So this year in 2015, hospitals will have their reporting year started in October 1, and it'll actually continue through December 31st of this year. So they actually have 15 months in the reporting year, in the 2015 reporting year. So all providers going forward, whether they're hospitals or physicians, will be measuring their meaningful usefulness, so to speak, in the calendar year. Another thing that's said within the proposed rules for stage 1 and stage 2, there will be no Medicare attestations before January of 2016. The reason for that is that they have to change the attestation site to agree with the new format that comes out in the final rule. So right now we have the proposed rule. We'll give feedback on the proposed rule for stages 1 and 2 by June 14th or 15th, I think it is. And then CMS will noodle on those comments that they've got in and release a final rule sometime maybe in August, September, who knows. And then that would give them time to actually make adjustments to the attestation website. So that means that even those folks who only are trying to do 90 days and want to do it early in the calendar year of 2015, they are not going to be able to attest until January of 2016. So it also has implications for hospitals, and we'll see some of this information coming forward in some of the future slides. Because hospitals were supposed to attest within 60 days of the end of their measurement period, which was their measurement period would end in September, so they needed to do it by November 30th. Now, both critical access hospitals and PPS hospitals will have until the end of February to be able to attest. So this, one of the comments that we may want to be concerned about in the first year is if the attestation website is not ready until January and we need to attest by February 28th or 29th, I don't know if it's 29 days, yeah, it would be the 29th in 2016. There could be a bit of a logjam on the attestation website, so that's something I think we would also want to be aware of, actually submit comments on. So in both of the proposed rules, the penalties and exceptions, by and large, are unchanged. The only changes have to do with anyone attesting for the first time in they would not be penalized either 2016 or 2017. Now that's new. If you recall in past, you had to, if you're, let's say, a provider, and you're attesting for the first time in, let's say, calendar year 2015, you would be penalized in 2016 unless you attested before October 1st, because CMS said we needed 3 months in order to be able to make some adjustments to the payment system because we didn't want to have to claw back in January. So if you attested in 2015 to 90 days before October 1 as a professional, you would not be penalized in 2016 or in 2017. In a hospital, it was similar. They had to do it before July 1 in order to not be penalized in fiscal year 2016 or 2017. If as a professional you attested after October 1, but in the calendar year of 2015, so you attested, let's say, February 28th, let's say, you would have been penalized for 2016, but not penalized for 2017. This new rule, because we're changing everything right now, they're not going to penalize folks for either 2016 or 2017 if you attest during the attestation period that will start in January. And there's a question, which I will verify. The question is, so if we are attesting for the first time for a hospital in 2015, the attestation system will be unavailable for us to attest until January 2016, correct? That if the proposed rule is accepted as written, that is correct. However, we will have until the end of February 2016 to complete the attestation. That is also correct. If the proposed rule is accepted the way it is written, that is correct. And when we go to the 2016 year, we say all those in 2016 will not be penalized in 2017, 2018 if they attest before October 1. So for that year and that year only, both hospitals and professionals would have to the October 1 date in order to avoid the penalty the next year. So that would be attesting before October 1st in 2016. You would not be penalized in 2017 or 2018. But if you attested sometime after October 1 for the 2016 calendar year, for those first-timers, you would be penalized in 2017, but not 2018. Once again, for all, 2017 is going to require a full year of reporting. So other miscellaneous changes. There's always been state flexibility within this. And for example, if you're a Medicaid provider, the Medicaid sites may actually allow you to attest earlier. It's Medicare that's the one that you can't attest until January. But again, states have flexibility on how they want to do it. Another very significant change, which has implications here, and you'll see it in some of the objectives going forward, is that paper no longer counts. Be that as it may, you can question the wisdom of this, but they're moving everything to electronic. So let's say giving an after-visit summary on paper is not going to be counted. Paper just does not count. And we'll see the details in that in a moment. The other thing that they're taking into account is that some Medicaid providers may fall underneath the threshold, and consequently, in order to be able to attest and not be penalized under Medicare, they might have artificially had to switch systems when they didn't want to. Well, they'll be able to attest using the Medicare system, but not be forced to switch from Medicaid to Medicare. That's for the eligible professionals. Because as you may recall, you can switch only once from Medicare to Medicaid and not switch back, or vice versa from Medicaid to Medicare. So for those who are on Medicaid for reimbursement and want to remain on Medicaid for attestation, they're coming up with a methodology for you to be able to attest without being forced to switch programs. There's another question. The new provider is starting with our clinic September 1st, 2015. Would she be expected to attest, or would filing an exemption be the recommendation? We're going to talk about the exemption. That person has never practiced before. They do have 2 years, and that 2 years is still true. It was true before, it's true now. If they've never been in practice before. But since meaningful use follows the provider's number, if they've been practiced someplace else and have been a meaningful user someplace else, they carry that with them when they go to someplace else. If they were in a previous site and they were not a meaningful user, they were not a meaningful user, yes, they could be a first-time attester with you, but they would need to do it right off the bat because they had been practicing medicine. So it's only for those people who are new out of practice where they get that 2-year exemption. I think I may talk about that a little bit later. So we have proposed goals and objectives have slightly changed. All of the meaningful use objectives right now fall under these categories. They're a little bit different than the ones that we had seen before. We have protect patient health information, electronic prescribing, clinical decision support, computerized order entry, patient electronic access to health information exchange, and public health and clinical data registry reporting. So, you may have heard about this before, but CMS has decided to eliminate some measures which they felt were topped out. And this is a listing of the measures for both professionals and for hospitals that they're eliminating. And we'll see in some of the slides later on some of their rationales for the elimination of these things. But some of these, off the bat, you may think are somewhat surprising. And their rationale is that they're looking to create greater flexibility. They're looking to reduce burden. And they're thinking that some of these, they've really been topped out, or they're measured in so many other different ways, that there's no need to continue to collect information on some of these. But there is a caveat here. The caveat may very well be that some of these were menu items. And if they were menu items, people may have been reporting on them because they did well on them. So we have a couple of other questions here in the chat. So printing out the electronically generated clinical summary does not count. That's correct. We'll get to the details on this in a moment. Okay, so just take a look at these. We'll go into the details on these in a moment. So here are the changes to Stage 1 from 2015 into 2017. I want you to focus on the first two columns for Stage 1, 2014, and Stage 1, 2015. The items in green are lowered requirements. The items in yellow are changed or increased requirements. So we see the security risk analysis and e-prescribing are about the same. Drug formulary, because it was a menu item, they actually are dropping your requirement to report on drug formulary use in Stage 1 in 2015. But it will be a core item in Stage 1 in 2016 and 2017. Clinical decision support, again, that's pretty much unchanged. One rule, drug interactions unchanged, medications are unchanged. Patient education actually now has become core. And remember, giving them paper doesn't count. It has to be electronic. Having access to view, download, and transmit your information off a website is required. Just the availability to do it. Medication reconciliation is now going to be a core item and not a menu item. Also note, as a professional, medication reconciliation sometimes required you to check the checkbox that it was either a referral or a change in referral or a change in status. I'm blanking on the term right now. But for most ambulatory professionals, they believe that any time a patient comes in, we could do it. So they did have a frequently asked question that came out that said that you could have as policy, you would do it for all. So you didn't have to go through the checkbox saying it was a referral or a transfer of care, and you could just count it on all of yours. It does not appear to say that in the revised rules for stage 1 or in the rules for stage 3. So that's something that I think some people may wish to submit. I know some of us are. The other change is that this is a minor change. For professionals, they'll have to do 1 out of 5 of these items, and these are public health items, or immunization registry, syndromic surveillance, case reporting, public health registry, or clinical data registry. And for the hospitals, they would have to do 2 out of 6 that would also include the reportable labs. So as I mentioned, in the changes to stage 1, in 2016 and 2017, you're going to need to do a full year of stage 2, especially if you started in 2015. So if we look at the changes, e-prescribing goes up 10% to 50%. Prescribing with a formulary for the hospital becomes a core at 10%. And it also becomes core yes or no for the professionals. Clinical decision support becomes 5 instead of just 1. And again, many people get scared by that one, but the CDS rule is really a pretty simple one when you think about it, because a lot of things can be thought of as clinical decision support. And again, we can help you with that going forward. Medications is going to jump to 60%, and you'll also be asked to track labs and radiology in your quote stage 1 of 2016. Load and transmit will be the ability to do that will actually be measured. Secure messaging will be measured, or it's actually a yes or no for secure messaging. You can do it, and at least one person has done it. We'll talk about that for stage 2 in a minute. And an electronic summary of care needs to be sent in 10% of cases. The other things that we have are the case reporting. So again, these are the ones that are going to be required for stage 1 in 2016 and 2017.
Hey there, Paul. It looks like we have another question in the chat box. And it is, can you talk about what availability to view, download, and transmit means? I've heard some say that unless the patient is registered to the portal, they don't have the ability to view, download, or transmit.
What our interpretation and the interpretations that I have heard is that as long as it is available, that you have the website up, that's all that's necessary. Whether or not patients have signed up is not a measure. So it's not like you have to have 50% of your patients signed up. So that really is, if I can go back here, that really is basically just they have access to view, download, and transmit. That means that at least half of the patient population have the ability, if they choose, to get access to a website where they could view, download, and transmit it. And that they've actually done it is the one where you actually would answer yes or no. So another question was patient education. Is it possible to create an electronically generated order for the document of giving a patient information such as a pamphlet? That is a good piece of feedback to provide. We don't have the answer to that. We are a specialty reproductive health clinic. The overwhelming majority of our medications are dispensed in our clinic. What does this mean for our ability to meet the e-prescribing goals? It would be, as I understand it, again, that's a good piece of feedback to provide, but as I understand it, it has to do with those prescriptions that are sent outside. That's sent to its internal pharmacy. So these are the ones that are deleted from stage 1. Summary of care, any method. That was a menu item, but since paper does not count, that one is being deleted for stage 1. What they have to have is an electronic version, has to be electronically available. So demographics, electronic access, vital signs, electronic access, problems, medication list, allergies, smoking. None of those are going to be measured because theoretically they need to be within the patient portal in order to be successful at having that information within the patient portal. So if those elements are not in there, that information is not available, so the portal would not be affected. That's the rationale behind that. Advanced directives for the hospital has been reduced, has been eliminated. I don't know why, but it's eliminated. Incorporating lab results, again, electronic access is the one where that one actually feeds. And that was a menu item. And again, people who reported these menu items that supposedly were topped out may have been people who did these items because they were good at it. Patient lists has been dropped, patient reminders has been dropped, and clinical summaries don't need to be given after the visit. They just need to be on the website. So again, it's electronic access. So people would have access to that information about their visit on the website. Now, as an aside, they say within the proposed rules that they fully expect everybody to continue to be giving paper, but my personal feeling is I honestly question the wisdom of that because that which is not measured sometimes has the habit of not being paid attention to and consequently decaying a little bit in how people perform with it. So these are the changes to stage 2. Again, if we look at the first two columns, there's not much of a change in stage 2. Again, for the hospital, using e-prescribing with the formulary in the emergency department or when they're being discharged, has gone from a menu item to a core item in 2015. So that's this year. And we see that same sort of change with the public health things, this immunization registry, the syndromic surveillance, the case reporting on those towards the bottom. For professionals, it's 2 out of 5. For hospitals, it's 3 out of 6. So again, we see that, we saw that change before. What's interesting, and pay attention to this because we'll see it on a further slide, the patients who actually view, download, and transmit, the green things in the middle, the patients who view, download, and transmit, used to be a core requirement of 5%. It's actually going to be whether or not they're able to do it, whether or not someone has done it. Same with secure message. If you have the ability and someone has done it. Interestingly, in my impression, the secure message has changed in definition too. The previous definition of a secure message, that change may actually only be for stage 3. But the previous definition of a secure message was the patient sent the message. Now, and it may just be for stage 3. It could be the provider sending the message as well. So these are the changes for stage 2. Not really significant, but there's some changes. But when you see the change between stage 2 and stage 3, again, you'll notice some significant jump. And again, these are the ones that are eliminated from stage 2. And again, the ones that you may notice that are maybe relatively significant are as you go down that halfway, you see family history is being eliminated. And I don't know that family history is the requirement in the electronic access. At least I didn't see it as one of the required ones. Yes, patient reminders is going away as a specific element. At least I did not see it in the notice of proposed rulemaking. To answer that question on the side. We mentioned advanced directives going away. EMAR, which was a core element, is going away. Imaging results, I guess, theoretically is on e-access, but not really specified that way. And where is it? I'm not finding it, but provider notes. Provider notes, which used to be 30% of patients had to have at least one note, which to me is kind of, first I think that's kind of lame. provider notes are becoming optional because they're no longer going to be measured because they're supposedly in the summary of care document. So these are the ones that are eliminated for stage 2. So now if we look at the changes in 2017 from stage 2 to stage 3, here we see some significant jumps. And this is half of them. That EP is actually e-prescribing for professionals. That jumps from 50% to 80%. The professionals need to use a formulary. That's unchanged. Critical access in hospitals for prescribing with a formulary goes from 10% to 25%. No change in CVS or drug interactions. And medications, labs, radiology jump from 60 to 80 or 30 to 60%. And patient education, which is now electronic, goes from 10 to 35%. Again, this is stuff that needs to be electronic and not paper. Paper doesn't count. More on stage 2 to stage 3. Remember when we said have access to view, download, transmit, or an API? It's going to become core in stage 3. View, download, and transmit. This one's pretty unclear to me. They say you need to do 2 out of 3 of these particular elements. So one of them, they say in their proposed rule, you need to have view, download, and transmit, or allow patients to use an API in order to retrieve their information. So if it's used view, download, and transmit, 25% of the patients need to do that. Now remember, in stage 2 now they've made it so that you just declare that one person can do it. Now they're saying 25% of the people must do it by stage 3 in 2018. They're also saying it could be 25% are using an API or an application programming interface where you can use some other device to be able to retrieve information out of the electronic health record. So BDT basically means going to a website, you can see it, you can potentially download it and send it on. API is one where you have, say, a separate application that can actually interact with your EHR and use it to display your information. So they're saying either one would work and it would need to be at 25%. Secure messages is jumping to 35%. Again, that can be a secure message from a provider to a patient and not just a patient to provider. And incorporate patient or other provided data into the EHR. So patient entered data or data that's coming from some other location is supposed to be incorporated into the EHR, and they're requiring that to be done for about 15% of the time. Again, we'll go into greater detail on these, but this is just basically the opportunity to give you a high-level overview of this stuff. Electronic summary of care is going up to 50%. Incorporating an electronic summary of care when it comes from somebody else you've not seen the person before, 40%. So 40% of these new patients, you need to be able to incorporate their information into your EHR. Clinical information reconciliation. So that's basically medication reconciliation, allergy reconciliation, and problem list reconciliation. All those 3 need to be done, and it needs to be done in 80% of the patients. So that's a completely new core item for 2018 or stage 3. And then we have, again, instead of 2 out of 3 of those registries, we now have 3 out of 5. And a couple of them you can do multiple times. So, for example, both the Public Health Registry and the, I think it's the Clinical Data Registry, those 2, you can do multiples of those, whereas Immunization Registry, there's only one of those you can do, and Syndromic Surveillance, you can do one of those. So theoretically, for a professional that wants to do 3, they could do Immunization Registry and then 2 Public Health Registries. Or a hospital could do Immunization Registry and 3 clinical data registries, something along that line. So that's what's proposed for stage 3, which starts in 2017 and is going to be required in 2018. So those, again, deleted from 2017 when you go from stage 2 to stage 3. There's only a couple of them. Have access to view, download, and transmit is actually being changed to say we use either view, download, and transmit or an application programming interface. And again, medication reconciliation is being subsumed into the clinical information reconciliation. Okay. So we have another question. Explain more about the registries, please. The registries they could be cancer registries. They could be specialized registries for disease states. They could be, some of our states, for example, within our state, we have registries that the ICSI, Institute for Clinical Systems and Integration Management. They are somewhat vague, and I will mention that some of the feedback we've had, even now for stage 2 registries, has been, can you help us understand better what they are? So again, that's a good comment to send back to CMS so that they do a better job of explaining them. I'll try and do more when we talk about them on a later call, but right now at this time I'm going to say that would be a good thing to send back as a comment. So, certified EHR technology. In 2014 or 2015, you can use either the 2014 certified EHR technology or the 2015 certified EHR technology. And the 2015 certified EHR technology has been proposed in another proposed rule that we're not going to go into. That's also due for comment back. I think it's also on the 29th of May. We're not going to discuss that one on these calls. But basically, through 2017, you can use either 2014 or 2015 certified EHR technology to attest to meaningful use in stage 1 and 2 through 2017. If you're attesting to meaningful use stage 3, you need to use 2015 certified EHR software. And one of the things that you'll see potentially in the rules, if you take a look at them, they actually go into a lot of detail about which version you can use with which product. But essentially, we saw this before when we were halfway between using 2011 and 2014 certified software. You can use any combination of partial 2014 and 2015 to attest to meaningful use 1 and 2. But when it's time to attest to meaningful use 3, be it in 2017 or by 2018, you will need to use 2015 certified software. So we have another question. How do we document in the EHR that a patient has access to view, down, and transmit if they don't have to actually do it? How does that get recorded? I believe if they have access, you have to document. I believe you document that one person has done it, but if it's just documenting that it's available, it's just a yes/no documentation, just like you document that you have 5 clinical decision support rules in place as well. You may need to do a screenshot. I mean, the details of that, I think, will be forthcoming, and again, that's a good thing to put into a comment. And by the way, are we capturing all these chat questions? Good. Next one, if a physician was hospital-based in 2014, are they considered an NU1 or NU2 EP in 2015? If they've been completely hospital-based and have not done any Medicare Part B billing as a hospital provider, they would be invisible as a. That's a good question. They would be invisible. They're not a new provider. They would need to be at meaningful use stage 1 in 2015, but I cannot attest to whether or not they would receive penalties on that. I remember thinking about that years ago, but I don't know that was ever answered. So if they've never attested before as an eligible professional, they would be at meaningful use stage 1 in 2015. But I cannot say whether or not they would be considered a new provider and whether or not they would be penalized in 2016 unless they attest to meaningful use. Oh, well, yeah, in 2015 you don't need to attest until January, so I guess they'd be okay in 2016. Good, so I think that provider would be fine. So for clinical quality measures, there's really no change for reporting for 2015 and 2017. Same methods, same domain requirements as 2014. Again, in 2015, they do have any 90 days in calendar year. For hospitals, they have the additional 3 months at the end of calendar year 2014, which is actually the beginning of the 2015 fiscal year for them. So they actually have 15 months that they can use any 3-month period. And they also say in their proposed rule for 2015 to 2017, that's the 1-2 proposed rule, it can be more than 90 days. It does not need to correspond with the meaningful use objective reporting period. So that's new. Typically, they had to both exactly correspond, but the proposed rule is saying they do not. Again, for quality measures, it's a full year reporting except for first years in 2016. And for 2017, it's a full year for all except those first who are doing meaningful use for Medicaid only. Medicaid only still can be 90 days. Okay. Attestation, no changes to the method. Again, we talked about the deadline for attestation really is the last day of February for all, and for 2015, it's only first-time attesters. Okay, we have another question. Will any of the Stage 2 changes be retroactive to 2014 if a physician missed Stage 2 attestation only due to one or more of those changes? No, it can't be retroactive because the deadline to attest for 2014, no, it cannot be retroactive. That's not the type of thing that CMS would do. So, one of the things that we want you folks to be aware of is that with the going away of the extension centers were really designed to help people meet meaningful use stage 1. And once meaningful use stage 1 was met, to some extent folks were on their own. But now with the Quality Improvement Network, and now Lake Superior Quality Improvement Network, which serves Minnesota, Wisconsin, and Michigan, we can provide that support for meaningful use 2 and 3. We'll be providing educational programs like this today. We will also be providing technical assistance for those folks who need it. We also are setting up and we'll have learning and action networks to help you work amongst each other and on projects to improve the use of your EHR and understanding how to best optimize care through the use of technology. And also, again, the nice part about that, because it's subsidized through CMS, all this work for you is free of charge. So, and what I'll do, the last slide before I answer that the last question is, here are your contacts for the Lake Superior Quality Improvement Network. Rebecca is in Michigan, Candy is here in Minnesota, and Marnie is your contact in Wisconsin. And their emails are up on the screen here right now. So there's another question that pops up in the chat box, and please do any additional questions, please add them to the chat. When will we hear if all of these proposed changes go into effect? Well, that's the million-dollar question, because, you know, I've heard from CMS in years past, they say I better watch what I say here. They say it'll come out in spring, but we're never quite sure what spring it's going to be. We know that we're going to give them feedback for stage 1 and stage 2 by middle of June. And it usually takes them 2 to 3 months at least to be able to go through all the comments, because they have to react to and read all of the comments that come into them. So they'll go through all the comments and then come up with the final rule. And that final rule is likely not to come out until sometime in, I would say, in August or September. In fact, I wouldn't be surprised if it didn't come out until October, given the complexity of what we're talking about here with both the stage 3 and the stage 1 and stage 2 changes, and how actually interrelated they truly are, because even though they came out independently, we saw in the first couple of slides how some of the things in the stage 3 rule, the time-wide things, were contradicted by some of the things that came out in the stage 1 and stage 2 rule. So, a bit of advice for all of you folks who are trying to figure out what to do and how to approach this. If you're currently doing stage 1, you should do stage 1 as if all of those things right now, which were required in 2014, will be required in 2015, because again, some of them need to appear within your summary of care or the information that needs to be available electronically. And we don't know how that's going to be measured. So you most certainly want to do those things. You also want to pay attention to the ones that are menu items that became core. We saw those in some of the slides, because they may very well become core, so you want to pay attention to them. And additionally, as the year goes on, you also want to pay attention to some of those stage 2 requirements, because those stage 2 requirements are going to become necessary for you starting in 2016. So a word to the wise, aim high and hope for the best.
Hey, Paul, while the hour is winding down here, it looks like there's about 5 minutes left for people to submit questions. And feel free to submit those in the chat box. And Paul, it looks like we've had a couple that were submitted to me privately, so I'll go ahead and ask those. Please review any summary of the care/referral process changes for summary of care 2015 stage 2.
The summary of care referral process changes. The only depth I want to go into it right now is it needs to be done electronically. On the next call, if you're talking about the ones for stage 1 and stage 2, we'll have that call, I think, on June 1st, and we can go into depth on that particular one, but I'm not prepared to be able to do that right now.
And then we have another question here. You mentioned at the beginning that if you are first reporting EP to meaningful use stage 1, you would follow meaningful use stage 2 with exceptions. Is that correct?
That is correct. They do say in the meaningful use 1 proposed rule that you would get exceptions for 2015 for anything that you did not choose to do or you had not planned on doing in 2015. There are some exceptions, as I mentioned. Some of the ones that were menu items are going to become core. So you want to pay attention to those 2 that I have in the screen. And then look at the requirements and the rules. We'll talk about the specifics of those things in a future call.
Right, and that call that Paul is referring to is our upcoming webinar that will focus on changes to stage 1 and 2 meaningful use on June 1st from 12 to 1 p.m. And while we're on the Central Time, and while we're on the shameless plug here, we also have our call next week, which will cover stage 3 changes to meaningful use on Tuesday, May 26th from 12 to 1 p.m. Central Time as well. And if you haven't received invitation to that, you will receive one here on Wednesday. So it looks like we have room for a couple more questions here, Paul. And while we're waiting for people to submit them to the chat box, I'm going to go ahead and just urge people to take the evaluation that you will be prompted to after you leave today's webinar in a couple minutes here.
I do urge that you do submit your comments to CMS because, again, they do their best job to come up with rules that they think that make sense, but they don't experience what you and I experience in the war zone, so to speak, or out in the field. And they cannot imagine all the different nuances that can occur in different practice sites in different locations. So, again, we'll go into greater depth. We don't have a whole lot of time before they're due at 5 p.m. Eastern Time to be submitted, but do take some time to look at that. So what's the best resource for referencing all the information you gave today? The slide deck will be out shortly. That is one piece. From that slide deck, you'll remember, I think it was on the third or fourth slide, there are links to the actual proposed rules, and there are links to the places where you can submit your comments. Those are the best resources that I can identify, at least at this point in time. There are many comments that are floated around from different organizations. You may want to look at your professional society or some other place because many folks have done it. You're also able to review comments that have already been submitted on that CMS website as well. So you can see what others have had to say too if you wish. So that's out there.
So I think with that just about time on today's call. It looks like we are out of questions in the chat box. And just to let everybody know, the slide deck and the recording for today's webinar will be posted to the Lake Superior Quality Improvement Network's website, LSQIN.org, in the very near future here. And please take a couple minutes to take our evaluation after you leave today's webinar. Great. We'll hope to see you all next week, Wednesday, 12 to 1 p.m. Central Time. Tuesday, thank you, Sandy. Tuesday, May 26th, 12 to 1 p.m. Central Time.
You would do it Memorial Day.
Thanks, everybody, and thank you to Dr. Cooper.
Bye-bye.